Steve is the chief psychologist over at the VA, and he's an expert in teaching individuals how to do motivational interviewing as well as an expert in it himself. So we're delighted to have him here. We are going to be doing some experiential exercises again, so if you have a chance to stay through the whole thing, I think that would be great and helpful, and we will be videotaping this so that you can access it at a later date. All right, so without further ado, I'll turn it over
Great,
to
thank
Steve.
you. So how many of you were here last time? Okay. I'd like to ask if anything that we discussed last time somehow permeated into your work. And if so, can you share an example of that? A time where you felt you used some aspect of motivational interviewing.
I used some scaling questions for the patient.
Yeah, and how did that go?
Just did today with the patient. Good. I think it put things into perspective for her about how high and low her anxiety can get.
Uh-huh.
It was, I used some kind of scaling in the sense of like, what this situation, how anxious does it make you? This situation, how anxious does it make you? And it said, well, this one seems to make you clearly more anxious, so this one seems less anxious in that respect.
Uh-huh.
So that seemed to, I think just put things into perspective for her and made her feel a little more comfortable.
Good. So sort of a version of the ruler technique.
Right.
All right? Good. Anyone else? Or am I moment at home with the kids, with the significant other, with the parents? It's all okay. It's ethical, depending on the circumstance. Yeah?
I did have a patient who was drinking, and we were talking about recommendations for discharge, IOP level of care versus, AA meetings, and she just kept saying no to everything. And finally I said, so what would you like to do? Where do you see this?
Yeah.
And she really wasn't motivated to stop drinking. She just was interested in limiting, but not stopping altogether.
Okay.
So we talked about that.
All right. And then how did the conversation go once you found a goal that was acceptable to her?
Went more smoothly, other than her saying, no, I don't want that.
Yeah.
Yeah.
Okay.
Because that's where she was at. She
Yeah.
wasn't interested in abstinence.
And we talked about last time meeting patients where they're at. Why have an argument with them? Yeah. Okay. Anyone else? Any other MI moments? Yes, please.
Yeah, I'm working with one patient who is an inpatient, and she is frequently having some kind of verbal argument with nursing staff. And when she had that argument, the nursing staff often forget some procedures or give her medication that she needs. So we talked about it while validating her frustration that she cannot control her anger and cannot help shouting at them. But at the same time, kind of discussing some costs of this behavior.
Yes.
And, because it was not really, I wasn't forcing her to, this is bad, this
Yes.
is going to make you even more frustrated.
Yes.
Because I didn't really push her with some specific pathway. She was more amenable to take other approaches for next time. So we'll see about that. I don't know for this week, but next week I'll see and check where she is.
Okay. So you use a little bit of MI to help her think about the effectiveness of her approach and if there might be a better way of going about it to get her needs met. Yeah. Good. Excellent. Excellent. So you only get good at MI if you practice MI. It has to be a conscious decision on your part that you're going to use this, and better yet, hopefully maybe have someone observe what you do in order to give you some feedback and coaching along the way. Again, it's up to you to decide, but I'm glad to hear that for some of you, you found moments where you could fit it into your practice. So what we're going to do today is to expand upon the fundamental skills that we discussed last time, Last time, if you recall, we talked about the overview of what motivational interviewing is, its origins, some of its key elements and components. We talked about the essential sort of two components, the relational skills that have to do more with the patient-centeredness of the approach, and the technical skills being more about how you elicit or evoke change talk, and how these have to go hand in hand. That's what makes it uniquely MI. And then we focus mostly on just a quick review on open questions, some practice with reflections, and just a note on affirmations and summaries, your ORs. So this time what we're going to do is move, and so that was all the engaging process. Remember, engaging was the first step, focusing. After focusing, evoking. Fourth step, planning. So I'm going to try to give you a further taste of MI by looking at the last three processes all in an hour and 45 minutes. We'll see where we get. And depending on our timing, I will show you a clip of me doing MI with a difficult, quote unquote, difficult patient who, similarly to, it sounds like your patient, did not necessarily recognize drinking as a problem. So, all right. Any questions from, I know from last time, it probably seems like years ago. Any thoughts or comments or questions from last time? No. All right, then away we go. So one of the things that you often are having to work with clinically is the fact that people don't have just one problem. There are multiple potential targets for motivational enhancement. And so how do you, in a brief interaction, decide on the focus? Motivational interviewing is behaviorally specific. So what are we trying to enhance someone's motivation to change? And so you commonly are dealing with individuals who may have problems with alcohol use, you may have problems with drug use, they may have other comorbid psychiatric conditions. They may have medication adherence issues and treatment adherence issues. They may have housing problems. They may have HIV risk or be HIV positive. They may have medical issues and more. And so these are the individuals that you're focusing on. Now you walk in and you have roughly, what's your average sort of encounter with your patients?
20 minutes, half hour.
20 minutes, half hour. It would be hard to tackle all of this. And so what do you do in order to bring focus to the session? And so what we often will do is, unless there is a critical need for you to set the agenda, we have the individuals set their own agenda, what they feel ready, willing, and able to discuss. And you can negotiate that as well. So you may have clearly important medical information or some updates about medications or whatever the matters are, where you will include that in the agenda while giving them some choice, and then you figure out within the time I have how much time you'll spend on both. So one way to do this is just a very simple tool, which is just have a piece of paper, and as the issues are being discussed, you just write them down. Just write them down in a clear visual. Or if you know them ahead of time, you just write them down and say, you know, I know, Steve, that there are a lot of things going on in your life right now. These are some of the things that I could see from reviewing your chart or the last time we talked. I'd like to follow up with some questions you had about your medication, but in addition, what issue would you like to talk about more today? And then they pick one. And then that becomes your target. So it's a collaborative process of setting an agenda. This is often very helpful in brief encounters. It works pretty well because it's so simple and commonsensical. Right? Anyone do this? Could you see the utility of this? Okay. So I'd encourage you to give it a shot. Next time you walk in and you go, where do I begin here? Yeah.
I guess one of my worries is if I were to do that, because I have a patient who I just saw today actually who has numerous issues, but if given the option to select, would not choose the drug use. Choose
Yeah.
everything except for that when it
Yeah.
was the most pressing issue
Yeah.
at the time.
So you might say, we got lab results back. I'm just making this up, of course. And I want to go over the tox screens. And in addition, what else would you like to discuss? So this is why I'm saying there's a negotiation. It's not to usurp your clinical skills and your professional expertise, but in MI, we're trying to keep that sort of equal playing field where everybody's bringing expertise to the table, and we must keep engagement if we're going to have a conversation about anything. So this is a way to keep it collaborative, allowing the patient to have direct input into what the focus is of the encounter. Okay? Now, if you want to talk about the drug use, as an example, and they say, I don't want to talk about it, then you would have to think about how you're going to handle that. Just because you want to talk about something doesn't mean other people want to talk about it. So we'll get to that later. All right, so this is a simple tool. And I think what we'll do is spend our time on a few other things rather than this activity. So we'll move on to, assuming you have someone engaged and you have brought focus to the session for the time that you have, then the next process of motivational interviewing is evoking their motives for change. So how we draw out the things that might favor change. That's the key component of motivational interviewing. That's the technical side of it. So in the context of being patient-centered, you are looking for opportunities to draw out reasons for change, desires for change. We'll get into all the categories of change talk. And when people are spontaneously describing things that might support change, we ask them to tell us more about it so that they elaborate on it. In essence, remember, the simple definition of motivational interviewing is helping people talk themselves into change. So you're taking things within them that they may have lost sight of, or we help them discover, or they knew but it's helpful to revisit. And we are getting them to marinate themselves in this conversation such that they might decide that on another sort of thought about this matter, maybe it makes more sense to change than to stay the same. It's in brief what you're doing in motivational interviewing. And you're not persuading in the sense of presenting arguments to them that are not their own arguments. You are listening for the things that are true for them by drawing it out of them. Okay, that's really the key. So it's not so much manipulation as it is sort of self-discovery. So in motivational interviewing, we have a ton of technical components of motivational interviewing that you have the option to use. Hi, Paula, how are you? And so obviously in a few hours, we're not going to be able to go over all of these and practice them, but I just wanted you to see that motivational interviewing is, has a variety of options for you to work with people, and it's really up to you to decide in the moment what makes the most sense. So if somebody is not even appreciating the problem at hand and the individual doesn't think it's a problem, then you would want to concentrate on strategies or components of MI that might help that individual think of this matter as more of a problem than they initially believed it to be. All right? Other people, they'll tell you chapter and verse why it's a problem, and they still don't change. That may be because they don't feel they're able to change or have resources to change. So the motivational evoking that you would do should center on that. How might they feel more efficacious to bring about change in their life? So it's these two dimensions, importance and confidence, that are often at the heart of how you work with people with motivation in motivational interviewing. So I'm going to go over a couple of things, but first and foremost, in order to be able to evoke change talk, you need to be able to recognize it. so that it provides a guide for you. In motivational interviewing, we have a direction in the session, and that means that we are trying to move people towards increasingly frequent and durable arguments for change. And so we have to hear what they're saying and also appreciate what they're not saying that we might need to further explore or draw out in order to help them sort of come to the conclusion that change is the way to go. So these are the different components or the categories of change talk. It's been referred to as the darned cat. And so desire statements are anything that a patient says that indicates how they want to, they wish for, they would like to change, that there would be something desirable that would occur as a result of change. Or the opposite would be that they don't want these certain things to continue to happen that are negative in their lives. So you listen for that. Ability statements, anytime they speak to how they can make a change, how they could do something that would make a difference on whatever the target behavior is. These statements are really important to getting at their sense of confidence and efficacy. And similarly, if they see continuation of the problem as thwarting their true capacity to do other things in their life, that would be supportive of ability. If I were to stop using it, I would be more able to do X, Y, and Z. Okay? Reasons for change would be the good things that happen if I stop this behavior and the bad things that will happen if I continue this behavior. And so we're trying to draw that out, the old decisional balance, if you will, with one caveat that we'll get to. And the need for change are those things in an individual's life that are most important to him or her that conflict with the current status quo behavior. So if my ideal self is a good father, and I'm also shooting dope, and that has challenged my capacity to be a good father, then that might create for me a need for change when I bring those things together. A lot of people avoid thinking of those clashes of values. They just sort of they don't want to think about that stuff. So in motivational interviewing, we're often helping people get to their core values and most important life goals and how that fits into what's currently happening. That's a way of developing discrepancy, making people a little uncomfortable as a way to then help them see a path towards change as a way to resolve that values conflict or that failure to be able to reach for an important goal in their life. So all of this is what we refer to as preparatory change talk. It's sort of getting somebody ready, willing, able. And then at some point here, you're looking to see, is someone ready to state true intention to change? Are they going to give you some language of saying they will make this change, they promise they will do it? And that becomes a very important indicator of switching over to the planning stage. It doesn't make sense to plan for change when someone's not committed to it. We might provide them information about resources or things that could help them to boost ability, but ultimately, for true planning to occur, there needs to be some kind of commitment to that. And so when you don't hear a commitment and you're trying to get them to agree to a treatment plan and you're finding it's difficult, it may be because they never said, I'm going to do this. And in fact, if you jump to this while they haven't yet made the commitment, you often will have motivation decline. People will start arguing the opposite side of what you're trying to promote. So you're part of this process. And it's this delicate, remember, dance, not wrestle, that we talked about last time. So if an individual commits, then we're interested in how they're going to activate those motivations in order to make the change. So what will they consider doing? What are they willing to put in place? What steps are they ready to take? This is all part of the change planning process. And we do ultimately need to see what they can do to move them in that direction. The action speaks louder than words, those initial small steps. So any of the things they might do in the moment that they talk about with you, like, well, yeah, I got rid of the phone number of my dealer, or I went to a meeting, or I called the therapist, or I took the medication for the first time. Whatever the thing is you're targeting, these are strong indicators of strengthening of commitment. So these are all ways in which people can talk about change, and the key is that you hear it, you recognize it. So to help you do that, because I know you want to develop your skills in this area, I'm assuming so, I'm going to read an example, and then I want you to tell me if there's change talk, and if so, where is it? I know I should come to see you more often, it's just that most of the time I can't get a ride.
I know I should.
I know I should come to see you more often. All right. Now, some people might focus on that, and that would be great. That would be very much of a motivational interviewing mindset. Tell me more about why you feel you should come to see me more often. How come you feel you should come to see me more often? Or a reflection. You feel it's important to come and see me. Right? Now, what's the patient likely to talk about at that juncture? If I said any of those things.
Reasons?
Yeah, so you see how it pulls for the change talk? Now, what if we instead were focused on the second part of the sentence? Well, how come you can't get a ride? Case management, problem solving. How come you can't get a ride? What will you hear? All the reasons why they can't come to see you. So you affect the probability of what someone discusses. If you do it the first way we discussed, you're more likely to get self-motivational statements. If you do it the second way we discussed, you're more likely to get sustained talk. So you get what you ask for. That's why hearing change talk is so important, because in MI, generally speaking, we put more emphasis on the change side of things, and we ask more about that. We attend to sustain talk for engagement purposes, if that's where a person is at and they want to discuss that, or they keep bringing it up as a reflection of their ambivalence because maybe we've overshot in our emphasis on the change side, and they want to remind us, well, it's complicated. There's something else to it, or I'm not so sure I'm ready. So it's a signal to us too. All right, let's try another one. I don't need to stop drinking. I need to cut down on my drinking for sure, but I don't need to stop.
They need to go down.
Yeah, so here we have sort of change talk in a bit of a resistant sandwich, right? And people can become, depending on their philosophy of addiction goals, riveted on the beginning or the end. Well, why don't you think you need to stop? You have fatty liver disease. You know, so then what would a person say? Why they don't need to stop. Instead, if you said, oh, wow, how come you feel you need to cut down? You're thinking about cutting down right now. You're going to get change talk. And anything said here would ultimately support that goal if at some point they come to that goal, right? So go for the change potential. Don't be like a deer in the headlights focused on the resistance. Then we become part of the thwarted process of change because we're actually leading people there. All right, let's try number 3. I don't want to go off on her. She just keeps going on about the past and shoving it in my face as if she wants me to hit her again.
Don't want to.
Yeah, so a couple people cringed at this one. So I don't want to go off on her. That is critical. That's a desire statement to change domestic violence. So if you reflect that, you don't want to go off on her. Usually that'll be a door opener to a conversation about that, rather than maybe launching into a psychoeducational moment about there's no justification for violence. And you can include the finger wagging in that lecture too. Right? That might get you a very different reaction for someone who's potentially sensitive to confrontation. Right? So again, strategy, mindset matters in motivational interviewing.
Can you just give example of how you would chime in with, I don't want to go off on her? What would you say?
Well, so you could say, tell me why you don't want to go off on her anymore. What's making that hard for you right now where that doesn't seem like a good idea anymore? Is that what you're asking? Like, how do you draw it out? Yeah. Or you just reflect it. You don't want to go off on her anymore. And usually the reflection itself will elicit elaboration. Even more so than questions, believe it or not. Yeah. Okay. 4. That program might be good at helping some people, but not me. I can change by myself.
I'd say I can change by myself. Ability.
That's a strong ability statement. I can change by myself. Bravo. Yeah. This could elicit people's, again, their expertise by saying something like, an addict alone is a person in bad company. Or, well, how many times have you tried that before? Right? And so there are all kinds of things we think we may know better than, especially for people we know well, where it has been a very difficult course. But again, let's talk about what makes this person, in the midst of maybe all these previous failed attempts, think that at this moment, at this time, he or she can change by him or herself. Isn't that fascinating? Well, I hope so, because that's, again, the mindset of MI is get fascinated, not frustrated. Right? People are wonderfully interesting when you really think about it. Yeah. All right, so mindset, change talk, recognizing change talk. So what I thought we could do is, I'm going to pass out, take, let's say, 2 Post-its and just pass them down. And what I'd like you to do is write down 1 change talk oriented statement and 1 resistance statement. On one statement per Post-it. Something that would hit on a change talk statement and something that would be more of a reflection of sustained talk. So the opposite. I don't want to change. I don't feel I can change. I've got no good reason to change. I've got every reason to keep drinking or not taking my meds or ignoring the treatment or whatever. I don't need to, so just flip it around for the resistance. And you can think of examples from your own practice where you can remember something that someone said to you, you're like, whoa.
So just like you did put something that has both elements.
So no, I want you to write 1 statement that's a pure change talk statement, and then another statement on a separate Post-it that is a pure sustained talk statement that you could hear a patient saying to you. Everyone have?
Sure.
Oh, if you need pens, don't let that get in your way. Here you go.
students put a change statement, for the other one put a
A sustained talk, like an argument against change.
Gotcha. Okay.
Yeah. So an argument for change, an argument against change. And you can pick the behavior, it doesn't matter. Once you have them, I'll just collect them. Thank you. Thank you, sir. Thank you. Awesome. Thank you. Thank you. Thank you. Great, thanks. All right, while we're just waiting for a few more, I'm just going to mix them all up. Any final contributions? Good or? Thank you. All right, so this is what we're going to do. I'm going to read these one at a time, and if it is change talk, I'd like you to drum the table, because we're drumming for change, okay? We're excited about change talk. If it's sustained talk, silence. We don't want to put too much attention to it, okay? Yes, it's true. I'm asking you to do this. So, change talk, sustained talk. Okay, so here we go. I'm going to read it out loud. I want to change my eating habits. That was like a real freebie. Jeez. Glad we're not playing for money here. I know it's important to exercise daily to sustain good health. It's change supportive. Exercising daily is difficult with everything else going on in my life. I bought a pill box this morning. Okay, so that would be taking steps. I have tried that many times, it doesn't work. Okay, so sustained talk, which would be inability. I'm just not ready. When I'm ready, I can stop in a moment's notice without help. So it's an interesting statement. So you see the change potential, but the person has asserted very clearly, I'm not ready. So in the moment, I'm not ready. But when I am, I can do it without a moment's notice, without help. So how might you respond to that in a way that could at least kindle some motivation for change? What might you say to that?
What makes you think you could do it without help?
What makes you think you could do it without help? So Now, intonation would mean everything with saying that. So if it's like, what makes you think? Then it's kind of like, justify that ridiculous assertion, you know? Or if it's true curiosity, you know, what makes you think you could do this without help? That would get you a very different response. So it's not just the words you use, it's obviously the way you say those words. Yeah. Other ideas on that one? What else you were going to...
Oh, why would you want to stop?
Why would you want to stop? Again, why is one of those words. That sounded fine, but you could also hear someone say like, well, why? You know, it has potential for justification and judgment. So MI is actually a very language-sensitive approach. You really have to kind of think about what you're saying. So, okay. I wish I was able to spend more time with my family. Yeah, okay. So that would be desire. I want to continue working on my addiction, but I don't want to go to treatment. So we have change talk for addiction, for the behavior, but we have sustained talk if the target is treatment adherence or engagement. Yeah. So you see, even there, you got to separate out the two. Just because someone doesn't want to go to treatment doesn't mean they don't want to address their addiction. Or just because someone says, I'll go to treatment, doesn't mean they plan on addressing their addiction. There could be other important motives, like getting someone off your back, like the legal system. Well, it happens all the time. The legal system, you know, you're referred by probation. All right, I'll do what I have to do, and I'm going to use it as soon as I get out of here. Okay, benzos are not a problem for me. I need to treat my anxiety. So let's assume the benzos are the target here. Not a problem. So lack of recognition there. It's a sort of insinuation of it's not important. I know that my A1C is getting higher and that I need to be better about taking my insulin. Okay, good. I can't stand needles. I love vodka. It's the only thing that helps me sleep. I've tried everything else.
I like that one.
Do you like vodka too?
But I like the statement.
These are like patient.
Yeah, just
Oh,
exactly.
no, couldn't ever be. The line is fine, let me tell you, right? Okay. I know I need to find a healthier way to cope so I can see my daughter. Yeah. So probably we're venturing into the need area there. I want to see my daughter. I wish that I could have a better relationship with my husband. Okay. I don't need to try to quit smoking. I only know what feels. I don't know what you only know. All right, let's try this one. There are so many things going around me right now, and drinking is my only way to cope. I can't stop drinking. So you see, the inability issue would be the area you would try to enhance motivation for. I wish I could stop feeling so anxious, then I could stop taking Xanax. Yeah. So it's see how, isn't it fascinating? What's so fascinating about that? I wish I could stop feeling so anxious, then I could stop taking Xanax.
They see taking Xanax as a problem.
So there's embedded in this is taking Xanax is a problem, right? But they're taking Xanax in part because they recognize anxiety as a problem. So you have this sense of ambivalence with a change-oriented kind of bent to the statement. What is it with you guys in Xanax? Xanax is the only thing that helps my anxiety.
That's what they say.
So if you had Xanax is the only thing that helps my anxiety, you would say?
What else have you tried to help?
Nothing. Xanax is the only thing that helps my anxiety. So this is where you're in face of high resistance, if you will, or a strong argument against change. So you may have to go with that and just push it further. There is nothing else ever that has helped your anxiety. Xanax is the only thing. So you just push it to the extreme, but you have to do it because you really are curious. Like, do they really mean it is the only thing? And often you'll see people show another shade to it. Well, it's just the only thing I feel I can do now. Oh, what did you do in the past to manage your anxiety? It may not be working as well now, but what was that and how did it help you in the past? So you're kind of just, again, you're trying to evoke, kindle, see what else might be within. I can't live on dialysis. That is no life. I should
How
stop.
would you push that though? I mean, we've had
Well,
patients say that.
We don't push an MI. we cull, we encourage, we elicit. So, well, let me throw it out to others. I can't live on dialysis. That is no life. Try to introduce maybe a little ambivalence, assuming there was something said at another point. You feel caught. You would like to be able to live, and dialysis is a way to help that. And at the same time, you feel it's no life. Like trying to just, you never want to go too far ahead of someone. You want to see if you could maybe, you assume within all people is the capacity to change. And so you are looking for what the other side of the coin may be within that individual. So I hear this is they want a life. So another thing you can say, you want a life, and it's been really hard on how diabetes has caused you, or kidney disease has caused you to be on dialysis, or something. Yeah. I should stop because it's so expensive, but it helps me relax. So there's this ambivalence. I should stop because it's so expensive. That's the change side. But it helps me relax. That's the sustain side. Okay. I've never had problems because of my drinking. I am already sick, so what difference would it make at this point? So there's another interest. I'm already sick, so what difference would it make at this point? You're really wondering, is there a possibility that maybe you still have a bit of a chance? You think about that, or something like that. So what you're doing in MI sometimes, these are great examples. You're trying to find just that little spark, and you're going like this. You're trying to get something going that means something in them. And I've often said in my trainings, there's a wonderful paper that Bill Miller wrote years ago called Rediscovering Fire. And it really gets at that notion of trying to find that spark within individuals and seeing if that can kind of burn again. Let's see. Although other treatments for my pain didn't work, I might still consider trying another one. Right. Now you hear this one is interesting, the strength of change talk. I might still consider another one. So it's not like I want to know what my other options are, but it's in the direction. So if someone said, well, I might still consider trying another one, it's not the time to say, oh, great, all right, so here's what we're going to do. And then you sort of like the prescription approach. That's going to be too much because they haven't given you enough, they're not prepared yet enough. So you may be interested in hearing about other options. I'd be happy to tell you about some of those, and then you tell me what you think. So that's a little more meeting them where they're at, a little step forward, and we walk together. Rather than, great, come on. All right? So that's the dance you're doing there. All right, so you get this sense, change talk, sustained talk. Hear the difference between the two. It is so important to master this skill in order to do motivational interviewing well. Because it's really the essence of the approach is what people are telling you, their experiences are, and being able to listen and reflect that back. So I was going to just share with you some examples of motivational interviewing strategies. And one of them that often comes up in medical settings is how do you exchange information with patients in a way that is adherent to the principles of motivational interviewing. So how do you do it without warning or lecturing or providing unsolicited advice to people? Those types of approaches of sharing information will generally garner resistance and cause people to argue against the information you're providing. So in motivational interviewing, if someone asks us for information, we provide it. It doesn't open the door to a lecture. It just gives us an opportunity to share information factually and objectively with folks. We want to sometimes share information that no one's asked us about. So a very simple thing you can do is just ask their permission. I have your lab test results back. Would you like to hear about them? It's more of maintaining, it's a stylistic maintenance of the collaboration. I've never had someone say, no, don't tell me. You know, I don't want to know. Be clear. Get rid of the jargon. Try to say things to people in a way they can understand them. And support autonomy. Just because you share it doesn't mean people are going to embrace it. What they make of it is important, and what they choose to do with it is important. It's up to them. It's up to them. And sometimes we lose sight of that. And I'll show you the clip with me where I'm constantly doing that. Check understanding. Just because we share it and people are looking at you, ask them how they heard it. What was their understanding of it? So that you make sure the message is received. And then these are the two that are most, these are sort of the most well-known approaches used in motivational interviewing: elicit, provide, elicit, and personalized feedback. So I was going to spend time on those two. And this is nothing new. Elicit, provide, elicit is, I think, right from the get-go in most medical education. It's the ask, tell, ask. I don't know if that's more familiar when you want to share information. So if you want to talk with someone about a particular topic, elicit from them what the patient knows. So what would you most like to know about, I don't know, diabetes? Thank you. Or what do you already know about diabetes? So that also is good for brief interventions, because sometimes people know a lot and they'll tell you, so you don't have to be redundant, and you can save your words for the areas that are most crucial. And then you provide information. And sometimes we ask permission, as I just previously said. Would you like me to tell you about a bit about diabetes? Or here's some more information about diabetes. And then you say your spiel. And then when you're done, you elicit again what the individual made of that. So what do you make of that? What does this mean for you? What more would you like to know? So you see this very collaborative approach in how information is shared. By the way, all these slides are going to be sent around. I sent them to Lisa, and she'll distribute them. Okay, so here's an example. You say, what do you think about the medicine you're taking? Patient says, well, the one medication makes me have to go to the bathroom a lot, and it makes it difficult for me to go out with friends. So honestly, sometimes I skip taking it so I don't have to excuse myself to go to the bathroom all the time. It's embarrassing. And then you say, that's understandable. That medication is a diuretic, and it works by reducing the swelling and water buildup in your lungs caused by congestive heart failure. That's why you have to use the bathroom frequently. When people in your situation don't take their diuretic medication consistently, they typically have trouble breathing and feel weaker because the water keeps building up. Sometimes people work with their doctors to reduce their dose on days when they have to go out, and a bathroom may not be conveniently available. Patient says, well, I feel caught between a rock and a hard place. I want to take the medication to feel better, but then I feel cooped up because I'm afraid to go out to see my friends. And then you say, you seem to want to strike a better balance. What do you think about working with me to adjust your meds a bit to help you feel more comfortable going out on occasion? So the elicit, provide, elicit. This collaboration. Okay. What do you think of this information sharing approach? And it's quite consistent with typical patient-centered communication curriculum. All right. Now, another common tool in motivational interviewing is giving people personalized feedback. So we look for aspects of the behavior, the issues that are caused by the behavior at hand that may be problematic and that people may not have fully known or considered. So in one of the famous addiction treatment studies, Project Match, where they tested 3 different treatment approaches, one of which was motivational interviewing for alcohol dependence, they had in it sort of normative data about where people fell in terms of their percentile among the United States adult population for drinking norms. And so, someone would report, let's say they ended up drinking 55 drinks a week. You would say, oh, Steve, do you know when you drink 55 drinks a week, you're drinking more than 98.7% of the adult US population? And I'd say, what did you say? Well, you're drinking pretty much more than almost all the adults in the United States. Well, everyone I know drinks like that. Oh, so it's surprising to hear, given who you spend your time with, that you are among the very few people collectively that are drinking like this. Wow. Yeah, and so on. It goes. So what you're doing is you're in some ways rocking someone's motivational boat. Like, oh. Now, in the study that Kim and I completed, we were working in the Women's Primary Care Center at Yale New Haven, and we were approaching women as they were coming into for their reproductive health care routine appointments. And we were inviting them to be screened for risky substance use, and then anyone who met the threshold, we were using the assist, was invited to participate in a brief intervention, a motivational interview for substance use in this study. And it actually had 2 arms. One was in-person MI, and the other arm was a computer-based MI, or electronically delivered MI. Both 1 session, 20 minutes each. And then we compared that to an enhanced usual care where we gave people all the referral information. It was sort of better than people usually get, but still not much, 2 minutes. In the 2 MI conditions, what we did is we asked people how much they typically use whatever their primary substance is per week, how many days per week, and then on average, how much are they spending on it per day. And so we would then just do our crosswalk. So let's say someone is a cigarette smoker and they're smoking 2 packs a day. All right, so then they're probably spending about 20 bucks, right? 20 bucks. So, Steve, you're smoking, you're spending $7,280 a year on cigarettes. What do you think about that? Oh, $7,280, geez. Yeah. And then you say something like, if you could go back a year in time, Steve, what would you have preferred to have spent that money on? And so you're literally getting at what is most valued by people. And guess what they talk about? What do you think? Well, what would you talk about? You can go on a vacation. You could pay your rent. You could buy better food. You could get gifts for your kids. Some people talk about, I need a car. I can make a car payment, or I could buy a used car. All kinds of stuff. And so you get people to start really thinking about, is what I'm doing worth it? Quite literally. And so this was a very powerful activity in that study. We would always get these very strong reactions from people. Once we went off the charts, it was quite something. So that's just an example of the way in which you can use feedback as an intervention within motivational interviewing. Well, before we go, what do you think about that kind of intervention, and how are you doing that in your current positions? I mean, you have a lot of data available to you that I would imagine would highlight problems, health-related behavioral issues that are problematic. So rather than just springing it on people, you might do this elicit, provide elicit, give them some feedback, see what they think. Okay. So another very common thread throughout MI is to use evocative questions and reflections. So here you're taking your open questions and your reflections and really focusing them on things that are change-oriented, so on change talk. So a patient says, it started with a back injury at work and an oxy prescription. The pain became chronic and nothing was helping, so I took more pills and got hooked. Long story short, I eventually used heroin and then my life turned to hell. I can't stand living like this anymore. There's got to be a better way, and I'm willing to try anything. So in the use of evocative questions and reflections, we'll try to pick up on anything that would elicit more discussion of things that are change-oriented. You could say, as an example, well, what do you think is a better way forward? Right? We are assuming that there's more for an individual to say, so we want to create the environment in which the person can talk more about that. Or you might use reflections. You haven't given up, which is also an affirmation. Or you want more ideas about what you can do to manage your pain, and that will also help you address your problem with heroin and other opiates. And I'm sure we could come up with more. Right? So think of your evocative questions as an invitation to elaborate more about change. Think of your reflections as a highlighter that also is an invitation to elaborate about change. Okay? You haven't given up. I'm willing to try anything. You haven't given up. So this shows me, when I'm listening to people's sessions and training people in MI, it shows me they understand how MI works and they are working it in the session. Now, sometimes change talk is not apparent, but it seems to lurk there. You get this sense that it's there. So we talk about this as snatching change talk from the jaws of resistance. So let's say the patient stopped earlier in the previous vignette. So it started with a back injury at work and an oxy prescription. The pain became chronic and nothing was happening, so I took more pills and got hooked. Long story short, I eventually used heroin and then my life turned to hell. I can't stand living like this anymore. So, here we're almost going to lend change talk on the presumption that we feel it's implied, but it's not stated. So, you're going a little bit out on a limb, but you're doing so in order to be a little more evocative and a change supportive. So here you might say, you were and remain open to trying many different approaches for managing your pain, especially because the drugs aren't helping. Okay? Or, your life is a living hell with heroin. You want less pain and a better quality of life with heroin out of the picture. Right? A little stretch, but not out in left field. And how do you know if it's helpful? Well, how would you know if these kinds of statements would be helpful? How the patient responds, meaning hopefully they respond first. They start talking more, and what they say is change-oriented. Or in this case, even ambivalence would be moving in the right direction. Right? That's a sign that the reflections are useful and helpful in enhancing motivation. So I wanted to give you a little bit of practice with using your oars, if you will, to be evocative. So I would like, we could probably just do 2 groups of this, maybe. That would be the best way to go. One person is the speaker and describes a health-related behavior change issue, a real one. You know, maybe you're trying to eat better or exercise more routinely or stop smoking or whatever the issue happens to be that you're willing to talk about. And then in a round robin, the listeners, the first person will elaborate. So ask for an elaboration, more detail in what ways the person is approaching this health-related behavior. So you're first trying to understand it better. Okay? Then the next person looks for an opportunity to affirm. So affirm is catching someone doing something right in the service of change. Qualities or characteristics that can help change, efforts made towards change, just how, depending on how you look at something, seeing the change side of it. Okay, affirm. And by the way, after each of these statements, like elaboration, the person responds. Right? And I ask whoever is the speaker to really respond. This is a practice exercise, not an opportunity to stump the chumps. Okay? Then affirm, then talk some more, speaker. Then the next person reflects the change talk, some aspect of change talk. The speaker responds, and then the next person summarizes. That's the idea that in a conversation there are a whole bunch of change talk statements. We view those as like flowers in the field. Conversationally, you're picking those. You're picking those. And you choose to summarize them in a whole. So you make this beautiful change talk bouquet, and you're just presenting it back to the person and, change, okay? That's what you're doing. That's what an effective, strategic, if you will, evocative summary does. It kind of brings it all together. Because most often in conversation, people don't have it all organized. So that's your job. Okay, does that sound clear? We're going to do one round, and then everyone will shift. So you keep going until everyone gets a chance to do this, all aspects of this. So it'll be like maybe 5 rounds within the group. So let's talk about the activity. Just how was it trying to use your oars in a more strategic, evocative manner?
Good.
Yeah.
You really have
Challenging
to be
at times
conscious of
with
it.
our-
Yeah.
Yeah.
Exactly, the consciousness of it, that this takes practice.
Yeah.
Yeah. Yeah, and some of you had to practice this in challenging waters, right? Some of the problems that were put forth were not necessarily seeping with change talk. So it made it a little bit more difficult at times. But nonetheless, this idea that you have this mindset that it's part of the spirit of MI, evocation is part of the spirit of MI. It's a way of being. You're looking for it, you're listening for it, you're trying to draw it out. It is so critical for motivational interviewing. All right, so let me show you just a few more things. Importance and confidence rulers. You've been exposed to this? Yeah? Should I move on then to something else, or shall we go through the importance and confidence rulers?
I think it's
We're good?
useful to
It's
show
useful?
it because there may be others who
Okay.
might watch it.
So, as you've heard me say, that in part what we're listening for is to what degree does something matter to someone, that they're interested in approaching change, and how confident or able do they feel in their capacity to make the change. And so you can ask people a simple 2 questions on this to get at that. So the first is from 0 to 10, with 0 being not at all important and 10 being extremely important. How important is it for you to, let's say, stop drinking? And a person says 6. So the question then comes back to you is, what do you say? You have lots of options. What might you say? Someone says 6.
Can you tell me? Go ahead. Go ahead.
No,
Please.
that's fantastic. You said 6. Why not 5 or 4?
Yeah. Or you could even go lower. For this question, I like going all the way to the 0. A 6. How come a 6 and not a 0? So that you really get at why it is so much more important than not at all important. But yes, you ask for lower, because if you ask for higher, you're going to get the reasons why it's less important. Right? It's not that important. Right? So you're pulling for the change talk. That's the strategy. And then if you wanted to try to develop the sense of importance, you would ask about what it might take to move from a 6 to a 7. Yeah. Right? Sometimes people will say things like, well, you feel it's about 60%. You know, it's better than, it's more than half important to you. You know, things like that. You can, whatever language, but the idea is you're trying to stoke motivation for change. Same time, you ask the second question about confidence in the same manner. And let's say the individual responds and says 3. What do you say? It's not a trick question.
Why not a 0?
Why not a 0? 3. How come a 3 and not a 0 in confidence? Or if they said 2, why not a 0? 1, why not a 0? So there's always a little bit. And then if they say 0, get fascinated. You know, it's like, really? So you might just state that. So you don't feel you have confidence at this point in time, and just be empathic. Or you might want to push it a little and say, so you feel that you have no confidence whatsoever to approach this at all. Like you sort of, you're just really pushing it. And then maybe there'll be a little ambivalence that emerges as a result of that amplification. And now, if you were working with someone that gave you this pattern and you've got about 15 minutes, where would you focus?
Get more confident.
Yeah, you probably would go for developing confidence. Although you could make the argument that it needs to matter a little bit more for the person to stick with this. And you might legitimately choose that. The key is, in brief interventions, you're going to have to make some choices about what would be most helpful to discuss. Now, usually you're going to get people that will give things higher importance, usually, unless they're pretty demoralized, and lower confidence. That's the most typical pattern. Sometimes it'll be the opposite. I usually find that's the people who are smoking marijuana. It's not that important, but if I decided to change it, yeah, I could. Yeah. So this is a nice way of cutting to the chase motivationally about what's going on. I would just caution you, these are the types of tools in MI where it could become very techniquey and you may lose the spirit of how you're conversing with people. So use the rulers as part of a conversation, not as your motivational interview. Decisional balance. So this is the classic pros and cons discussions with people. Now, this is not in any way unique to motivational interviewing. What motivational interviewing does, though, is concentrate on the reasons that would support change. So the pros for change and the cons for staying the same. In a full decisional balance, you would explore all the quadrants. Pros and cons of change, pros and cons of staying the same. So in that study that I told you, actually this is a different study, we're doing a multi-site study with case managers in AIDS care organizations. So they're trained in motivational interviewing. And what they do in that is in the midst of the conversation, they have people talk about some of the reasons they have for quitting or cutting down their substance use. 'Cause this particular project is all about people who are using substances in a risky way are, of course, less likely to be adherent to their HIV meds. And so we're targeting both, but the discussion is more around the substance use as the primary target. So in the midst of that, they have this sheet and they'll say, they'll reflect whatever was said, and then they'll say, you know, I have this sheet that contains other reasons that some people who are HIV positive have said are important to them, or reasons for quitting or cutting down. I'd like you to take a look at them and check off any of these that apply to you. And this way, you can get maybe a richer listing of reasons that may not have been spontaneously thought of. So you can combine, this is also can make things more efficient, and then you look at it and discuss it with the individual. So it's a nice way of doing more of a pros-con discussion. Right? I don't know if you have sheets like this, easy to develop. If you have certain problem areas you're routinely trying to motivate people on, make a bunch of sheets. It's a helpful tool. Recall is easier, right? So that's what we're trying to do here. All right, change planning. So at some point along the way, you're going to be hopefully getting to the place where someone commits to change. So they say, I do, I will, I intend to. And so you can come up with contracts. First, I was not someone who was an advocate of this because I thought it was a little hokey. But we did put it into the primary care trial that we did with women, and lo and behold, people found this to be really helpful, both the clinicians who were doing it in person and the patients. It provided a cue to summarize what was discussed. It provided a nice consolidation of what the commitments were, gist of the plan, and then we had everyone sign off on it, which of course a signature is a statement of commitment. So you can develop these kinds of things to discuss the components of change planning, whatever those may be. And often it's helpful to anticipate when certain things happen that might challenge the targeted behavior, what a person intends to do. So you're getting at implementation intentions as a means to boost the probability that people enact those changes down the road. Yeah.
Just curious in the utilization of this tool, what happens if the person was not able to fulfill this so-and-so contract? Is it then like kind of brought back to the next visit?
Yes. So you can only go as far as the patient is willing to go with you, right? And so you don't move to change planning if an individual isn't ready for it. So you acknowledge, you summarize whatever was discussed, and hopefully keep the door open for further conversation, either by another provider or the next time you may be on the unit in order to speak with them and see if you can get further. You don't push change plans down people's throats because they'll just cough them back up at you and spit them out. Okay? So change planning. Now, hopefully when you try some of this, you'll see that things do go generally well and that people will become more motivated for change. As long as you set the goal appropriately, too, for them so that they're committing to something that they feel is manageable. And remember, MI is more of a harm reduction approach. Any change, any progress towards change is something we're supporting. So we're not coming in with pre-established, ultimate goals for an individual. It's whatever it is that the individual can commit to. But sometimes along the way, there are going to be patients who are a little more challenging to work with, and they are not necessarily going to come along. And in that sense, there are two aspects to resistance. This term resistance is laden with history, and so in MI, we have evolved to talk about sustained talk, arguments against change, as well as discord. So you could have people who are supportive of making changes in their own lives, but they may not feel engaged with you. So they have discord in the relationship with the provider, but they're not necessarily opposed to making behavior changes. Sometimes people can be quite discordant in their style of talking to us, but they could be talking about change. I don't need your help. I don't need anyone's help. I can do this on my own. Now that could be confused with a resistant patient, but actually that's just music to my ears, right? Tell me about how you're going to do it on your own. You seem pretty confident. You don't need my help, and you don't think you need other people's help. Tell me how you're going to do this. It's hard to fight someone who doesn't fight you back. So don't walk into people's punches. It just doesn't help anything. So in MI, we try to manage the sustained talk and also keep people engaged and attend to discord if it arises. I may have said something that did not sit well with an individual. I might need to apologize or clarify or whatever, not to label the patient. So this is just an important development within MI, is deciphering out these two things because they're not the same and they may require a little bit of a different tact within the session. So I wanted to give you at least a sense of this patient process of working with someone who's not about change, just to kind of bring it to life and show you a clip of me doing this. It was for a recent brief psychotherapy book, and they wanted expert clips of people doing the approaches that were, all the chapters in the book. The only problem is this hyperlink doesn't work, so we need to get to the internet if we could. Let's see if I can. Whoops. So, okay, I'll just. Down, internet, okay, and then we go there, okay, and www. Let's see if this gets us there. Yes. Thank you. Thank you. Whoops. And I want to do, I think this is the one. So, all right, so here's the setup. There was an actor. The actor walks in the room. The actor's only told you have a drinking, you're supposed to play a drinking client, and you're not about changing. They were supposed to be a little bit ambivalent, but you'll see what happens. And so I know nothing because they want to make this real. And the cameras are going. One shot. So it's unedited. How do we do?
Hit the X maybe there, right there.
Well, what's been going on is I come under a little pressure.
At the right side?
Seek some
Go
counsel.
here.
I wouldn't be here otherwise.
what type of pressure have you been under? Well, that's
She claims I'm drinking
full
too
screen
much.
is unavailable.
That's fine.
That's her assertion. And that I need some assistance. She wants me to stop. I don't know that I'm drinking that much, frankly. But this is her claim, this is her assertion, this is her driving force at the moment. And so here I am. Not entirely of my own free will, but
Okay, all right. So this isn't something that you were thinking about much. It's
No.
just your wife has been bringing it to your attention.
yes, particularly more recently.
And what caused you then to decide that you were going to come in when you don't necessarily see this as much of an issue as your wife does?
Well, it was in essence to have some peace in the home. I was acquiescing to her desires, not necessarily agreeing with her claims, but it's been getting more intensive,
Yeah.
and I felt that it was to make her happy. I do want to make her happy.
Okay. Yeah. So you do care about the fact that she's worried about you. You just don't agree with
I think
the
she's
extent to which she's.
I think she's overblowing it. I think she's exaggerating.
So what's your point of view? What's your view of your drinking?
My point of view is that I enjoy drinking. I don't believe I do it all that much or all that often, and for me it's a release. It's an entertainment. It does help me relax. It helps me calm my nerves after working, but it's not anything that I need. I'm not drawn to it like it's an addiction.
And that's what you're hearing her
Yeah,
say.
yeah.
So tell me more about what you like about drinking. Then you mentioned that it relaxes you. Tell me a little
Yeah,
bit about how drinking fits into your life.
Well, I'm in a high stress employment environment, and when I come home or leave work, I do stop with the guys. We have a little troop of employees at work that we tend to relax together, and I'll either stop with them or I might come home. And after a tough day, and they are tough, frankly, and getting worse, a drink is a nice glass of wine, maybe a shot of scotch. It's a nice release for me. It settles me down. It lets me center. And to be honest, I just enjoy it. I like the way it tastes.
Yeah.
I don't think that's a crime.
And so drinking's been, just the way that you kind of relax at the end of the day.
Yeah.
You're under a lot of pressure and stress.
And it relieves the pressure.
It centers you, as you said.
It does. It does.
And what else about drinking has, caused you to feel like drinking is okay?
Well, I've heard and read about some of the bad indications, the shakes and the needing a drink in the morning. I never need that. I never have an eye opener.
Yeah.
And do you feel guilty? About anything that you've done when you've drink? I've never had a DWI. I don't drink and drive much.
So you haven't seen some of those types of problems come up. And
No, I've never
that's
seen
why
any of those.
It's almost confusing to you why your wife would be making as big of a deal out of this as she is.
Yes, and as I said, it's more so than it has been in the past, because I believe my wife, she worked for an ad agency and lost her job, a good job, 5 years ago, and since then she's had hunt and peck little things in retail here, and the economy here is terrible, and so she's been stores are closing, malls are becoming abandoned, and so she hasn't been able to keep a job for very long. And she hasn't worked anywhere in the last 9 months, so it gives her a lot of time to sit and think about problems and what she perceives as problems.
So there have been some hard times that have fallen, not just in your community, but also specifically on your family.
Yes, there have been some serious financial problems. We've got Well, to be honest, we've had some problems making mortgage payments, and we're a little concerned about the bank foreclosing, and that's on her mind. It's on my mind too.
Yeah, yeah, I can imagine. So you've got all that pressure on you. You've got the pressure at work, you've got the pressure of your finances, you've got your wife concerned about your drinking, and now you're concerned about even keeping your home.
Yes, but it doesn't compel me to pound down drink after drink after drink. I'm not a binge drinker.
Yeah, yeah. So, and in the midst of all of that, you're trying to relax and use drinking.
That's all.
And that way to center you.
That's right. Some people do yoga. I don't,
Yeah. So you drink as a way to calm down and relax.
Yeah, and it works very well for me.
So, what else has come up for you that might cause you to be concerned about your drinking? I mean, regardless of what your wife has to say, what do you think?
Well, it's not just my wife, unfortunately. My boss has been giving me a lot of stuff too. Not necessarily accusing me of drinking, but he's on me. He's on me all the time about reduced productivity. And he claims he perceives a lack of motivation on my part. And I think he's reacting to the overall picture. The whole company's in trouble. Everybody's doing less. We can't help that. It's the economy locally, it's the economy nationally,
Yeah.
and the whole company is on hard times. And it's like he's singling me out.
Yeah. And that seems really unfair to you.
Of course.
Yeah.
I'm the general manager.
Yeah.
So if anybody else falls off in productivity, it's my fault. It all comes down on me.
Yeah. So he's on your case too.
Yeah.
And what do you think about your productivity? Just beyond the bad economy and the pressures that are on everybody. What do you think in terms of your normal capacity? How do you feel you're doing?
Well, I'm getting a little older. Maybe I don't have the get up and go I used to, but I think I still do the job. We're not plunging into bankruptcy or anything, and I feel that I'm holding up my end. I think
You're doing the best that you can.
yeah, and I might have a little less. I might be a little less of a go-getter than I was, but who isn't?
Yeah. Under the circumstances, especially.
Well, yeah. I mean, the company's got its problems, and I don't think it's all my fault.
Yeah.
I'm shouldering a lot of the blame, a lot of the responsibility, and I don't think it's fair.
Yeah. So let me see if I've got this straight then. Your wife has been pressuring you to do something about your drinking. She's been concerned that maybe your drinking has increased in some way. You're not.
That's her
Right,
opinion.
that's her opinion. You're not convinced by that. What you know to be true is that you have been under a lot of pressure financially, in terms of having one income when you used to have two, trying to make ends meet, trying to make the mortgage payments, being concerned about foreclosure,
Yes.
and now all the pressure at work, and now your boss saying on top of it all, he would like you to be more productive, and he's noticed that there's been, from his point of view,
From his point of view.
from his point of view, a decrease in the amount of work that
Right,
he's
and I don't
doing.
buy it necessarily, but that's what he says.
And in the midst of all of this, you've been drinking to relax, as you have for quite a while.
It has not accelerated.
Mm-hmm.
I'm not drinking anymore, I don't
Yeah.
think.
Yeah. So I guess what I'm wondering about then is what would make you concerned enough to come in to see me beyond getting your wife off your case or just placating her?
Well, I did have a physical 2 months ago. And the doctor told me that my liver enzymes.
I'm just going to put it right to the end so you see how this is
which-
just the
and
beginning of the
this
session.
this makes some well, I'm not an expert on what the liver does for you, but I get guess it wouldn't be a good thing. It would be derogatory to my health and my well-being and the well-being of my family. And that's the most important thing. So there are real reasons from your point of view to be concerned about your health. You don't want to see your health failing on you in a way that would get in the way of being able to take care of your family. Yeah.
So I just wanted you to see the difference, even though we couldn't watch the whole thing. So what did you notice about that clip?
I noticed he didn't ask him to quantify his drinking.
Because I had to engage him first.
Mm-hmm.
He was fighting.
Mm-hmm.
He's fighting, and so I had to engage him. I had to not construe me as just another person on his back. Otherwise, his wife, his boss, me.
Now you.
He was just raring to make me part of that gang, and I just wasn't going to walk into it. And that was why I asked him about what he got out of drinking. I typically wouldn't do that, but he was so adamant that drinking wasn't a problem. I figured this is the road he gives me. I'm going to walk down it for a moment. And then we shifted. You see me trying to see, well, where might there be some issues? And finally we get to, well, it just occurred to me, I knew it was an actor, but I mean, that's all I knew. I'm like, who sent this guy? I'm supposed to show MI, and he's just not changing. He's doing nothing here. And I was like, well, why did you come to see me? And then this thing about the doctor comes up, and it turns out he ended up having, there were some indicators of him having some stress on his liver and early stage of liver disease. And that's when the conversation started to shift. And he sort of dismissed the doctor, and at one point I said, so you're not so sure your doctor's telling you the truth? And he says, well, I don't think my doctor's lying to me. And I said, so well, then how do you square that? And that's when we kind of got somewhere. So I couldn't be the enemy if I'm going to have that kind of conversation with him. And then it becomes the rest of the session. We focus in on the alcohol, and then we use all the sort of attempts to sort of bring him along. And what we learn is this guy feels like the world is being ripped from under his feet, and he's got 3 kids. The last one is ready to go to college, and it's his daughter, and it's his baby. And he fears he will not be able to provide support to her like he did his 2 older kids. And he finds that intolerable. And he feels his drinking is not helping that. And that's when we got to the need for change, and then he moves towards a commitment. Yeah. So as you see, this whole approach is sort of like a delicate dance, but is this the one?
Yeah, the one
Yeah.
on the.
But it's something you can learn and you can do. And I want to encourage you, we'll get past it. It's not a cookbook. I wish I could tell you it was, and there are things out there that would say, okay, do this and do this and do this. It's a good way to start, like you learn to dance, but you ultimately need to be able to shift and move it towards where your patients are, and be selective in what you do. And I just want to show you that study we did. Our MI conditions outperform the treatment as usual in Yale, New Haven's primary care, reproductive health care centers. And this was a randomized clinical trial, and we got nice effects over time for reduced primary substance use. And we split it out also for pregnant women, and we didn't have the power to analyze it, statistically speaking, but the pattern was exactly the same for the 180 women who were pregnant in the trial. So MI does work. Not huge effects, but clinically meaningful effects. I hope you use MI a little bit. Give it a shot.
Thank
Okay?
you.
Thank you.
You're welcome.